Hello, my name is Jialin. Here I want to present you to our review article. Are patients with primary glomerular disease at increased risk of malignancy? Glomerulonephritis or GN is an immune-mediated disease impacting glomeruli. Studies have shown the overall incidence of cancer in GN patients ranges from 5 to 11%, with lung, skin, prostate cancer, and lymphoma the most commonly described types. However, current research in this area faces several limitations. This includes failure to exclude patients with GN secondary to pre-existing malignancies, misclassification of GN types, inadequate exploration of risk factor, and increased likelihood of physician encounters, which can result in ascertainment bias because cancer are more likely to be diagnosed when you are investigating patients for other reasons. A summary of the existing literatures and the limitations can be found in Table 1 of the manuscript. Therefore, due to this limitation, the absolute risk of cancer in GN is still unknown. There are several potential mechanisms of oncogenesis in GN. Chronic activation of the immune system may increase the cancer risk, particularly lymphoma. Chronic tissue inflammations within specific organ can result in increased risk of malignancies in the same organ. And immunosuppressive therapies to treat GN could have direct toxic effect to specific cancer. For example, bladder cancer secondary to cyclophosphamide. And the overall burden of immunosuppressive therapies could decrease the immune surveillance, resulting in increased likelihood of cancer when combined with environmental exposure. This can be seen as skin cancer in transplant patients. Lastly, ESKD is known to be associated with increased risk of cancer, for example, renal cancer in patients on dialysis, and overall increased cancer risk in renal transplant patients. A summary of pathway to increase cancer risk in patients with GN can be found in Figure 1 in the manuscript. To improve our understanding of cancer risk in GN, future study needs to be large-scale with extended follow-up period. The study should include control population without GN with adequate baseline risk factor for cancer to control for residual confounding. It's also essential to model immunosuppressant drug exposure carefully and consider the presence of time-varying confounder when studying immunosuppressive exposure over time. For example, the prior immunosuppressive treatment can impact the current EGFR, which in turn will modify the future treatment strategy. While both of the EGFR and the immunosuppressive are associated with cancer risk, this will cause a problem of time-varying confounder. Lastly, future studies need to determine the appropriate approach for handling the onset of ESKD. In conclusion, the absolute risk of malignancies and knowledge of cancer-related risk factors is still unknown. There are several challenges need to be addressed in future studies to investigate this further. By doing so, we can raise awareness of the increasing incidence of cancer in patients with GN. And also, we can provide valuable guidelines to clinicians regarding appropriate cancer screening strategies for patients with GN. Thank you.